Okay. Hi, and welcome to Life, Love, Insight, Fertility Experiences. Today, I'm here with Dr. Jesse Hade, who is the Director of Third-Party Reproduction at Generations Next. And I have to say, I'm so honored and thrilled that he's here today. I have received such positive accolades and feedback about you, Dr. Hade. So thank you for taking the time to be here today.
Oh, thank you so much. Really appreciate it, Lori.
Yeah, no, thank you. And I was wondering, maybe some people are really familiar with third-party reproduction and some people are not. And I know that since you've gotten to Generation Next, you've done a lot of work there. And is there a way we could just frame what third-party reproduction is for people who are listening who may not have a good sense of it?
Sure. Third-party reproduction just really represents anyone or any modality where you're helping a couple achieve pregnancy, where either you're uh, changing the source of the sperm, the egg, or the uterus, where this embryo is going to be incubated in. And that's really what you're saying. You're bringing a third person who's not a member of the couple or the individual looking to achieve the pregnancy and have the baby. You're just bringing an outside individual.
Yeah, okay, that's great because I always say it takes three things to have a baby, right? Egg, sperm, and uterus. So
That's correct.
I like how
That's
you explained it. And so I know Generation X is doing a lot of different things for third-party reproduction. And many people think that it's very much age related, that you might need help. And I'm finding that it's not necessarily age related. Uh, and there's so many different types of people having babies today, whether you're in a heterosexual couple, same-sex couple, or a single parent by choice. The ages really range. I have people in my practice right now from 23 to 52 that are going through third-party reproduction. So that's surprising to some people. And what do you find in terms of that?
Yeah, it's not one size fits all. That's how I look at it. And everyone has their own unique circumstances and challenges. And the whole point of just being a physician and a clinician is just to understand the problem at hand and then say, okay, based on this finding or this is your potential, here are your options and how we can try and overcome the main obstacles and then say, okay, this is and then the job of the patient is to tell us how they want us to execute, and so we can execute the plan for them.
Right, so by the time most people get to you, they've already tried quite a bit, I'm assuming.
Some have, and I think for some, it's especially when you're looking to do either egg donation or sperm donation in a married couple or unmarried couple, doesn't matter. Anyone's been trying for a while to conceive. Um, that I look at it that they have to decide what are they really that they've exhausted all their options in life. That's how I look at it. A lot of people, it's an evolution. You have
Yes.
to have an evolution before the revolution.
Yeah.
Uh, so many people, and I understand it, that they want to have their own biologic child. But I think that when they know that they've at least given the shot and given it all that they can do, and they still want to become a parent, I think third party reproduction is an amazing, amazing way and great experience for most people.
Yeah, it is. I think ultimately it winds up being a wonderful experience, right? But I think what you said is true. They have to, or most people want to exhaust most of their options, especially if they're in a heterosexual couple, or even if they're not, right? They want to exhaust all of their
Right.
options if they're using their own DNA before they go to third-party reproduction. And that part of the process, I think, can be very hard and challenging on an emotional level.
Of course, of course. And then like, so it's the same thing for if people who are looking to use a gestational carrier, for example, because uh part of the joy of having a child is the experience of the pregnancy, and a lot of people don't want to give that up, and the cost is very expensive to use a gestational carrier. But luckily now we live in a state where it's legal to do use gestational carriers, and some people still call it surrogacy, but we could talk about that after. Technically, surrogacy is illegal. The difference between a gestational carrier and a surrogate is a surrogate donates both the egg and then carries the child, whereas even for couples who are doing egg donation and a gestational carrier, they have to be separate individuals, because you don't want to have the person who's carrying the pregnancy to have any biologic uh, uh, contribution to the pregnancy itself, because then they actually would have rights to the child if they wanted it.
Right, that's really scary on many levels when you're
Yeah,
looking at that.
right. So I think everywhere in the United States, surrogacy is actually illegal, but in gestational carrier is what people
So really what you
generally
want to
use.
do is, even if you have to use a donor egg, you want to be sure the gestational carrier is not the person whom you got the egg from.
Correct. They can't do both. And there are some people who come in and they want that as an option, and we tell them no.
Yeah, that's a huge shift, right? From, I don't know, years ago when people would use traditional surrogacy.
Right. And that's I've been practicing long enough that I was at the tail end where people were still doing things like that. But in the late 90s, early 2000s is when they stopped doing that.
Yeah, yeah. There was a lot going on with that. I I recall. So, I think it's a really good distinction for people to understand, because the terms are used interchangeably, and they're really not interchangeable. It's kind of like when I talk to people about embryo adoption versus embryo donation, right? And trying to explain the distinction between
Sure.
the two, and it becomes a legal term, legal terminology that's so impactful, especially with our
Yes.
legal system.
That's correct. And so, that's why there's so many avenues, and the good news is for people who do choose to do any third party service, especially like egg donation now, because of the advancements in cryopreservation and cryogenics for embryos and eggs, because 2012 is when it became off the experimental list for egg freezing, and it became in the mainstream. And a lot of companies, well, I won't say a lot, but I think some of the bigger companies and many of the tech companies pay for egg freezing benefits for many patients. Um, these are great opportunities, especially for women who are not ready to have children. If you look in the United States, and really all over the world, the average age of pregnancy is going up, it's increasing. The number of people wanting to have children is decreasing. So at least it's a way to hedge your bets. I always look at women who freeze eggs as it's really like a 401k account. You want to put your money in it, but hopefully you never need to tap into it. It's so because of the proficiency of freezing eggs has gotten so good, uh, we now have egg banks. So like when people do egg donation, it's the minority of them are actually doing fresh egg donation. The majority are doing frozen donor eggs, and they have amazing success rates if you utilize a good egg bank. There's usually you have some good guarantees. Uh, it's a fraction of the cost of traditional um, um, donor eggs, by putting someone through a IVF cycle and capturing those eggs and synchronizing it to your cycle.
Yeah, the only thing I usually, and maybe I'd love your feedback on this. Usually though, I find that when I talk to people about using donor eggs, and I talk to them the difference between fresh and frozen, aside from the price, is if they want to have biological siblings for the child, then
Right.
I usually say that it might be better to consider the fresh, because then there's more eggs, or to buy a couple of
Right,
lots.
and that's up to the couple, and that's why I always tell people you have to decide how many children do you think you want, and then based on the number of children is really how you should what the strategy should be. Are you going to go through an egg bank or through a fresh egg donor? Each has its own risk. With
Right.
eggs, they're not as hardy as embryos, so the survival rate from the freeze thaw process is not as reliable. It's excellent, but it's not as reliable. So if I had an embryo, for example, and I thawed that embryo out, and I'm talking about blastocyst, which is the end stage of embryonic development that you have to either freeze or transfer an embryo. A frozen blastocyst has about 98% freeze thaw survival. Eggs in general have between an 80 and 90%. Like I tell most people about an 85% survival rate. But once they survive that freeze thaw process, the outcome per survived egg is no different than the fresh eggs. So you're just dealing with a smaller subset, like you're saying, because they're purchasing somewhere between 6 and 12 eggs, let's say, for example. They're usually sold in lots of 6.
Right.
And based on how many you purchase, um, then that's one of the ways that you look and say, okay, for each 6 to 7 eggs thawed, you'll have a 90% chance of having at least one blastocyst. 60% of couples or individuals who have make the one blastocyst will also have additional embryos to freeze for future usage. And
Mhm.
the overall live birth rate per close to 7 eggs is around 45%. So it's fairly good.
Yeah.
It's really good
Improved.
for,
It's definitely improved.
yeah. And with fresh egg donation, because you're dealing with higher numbers of eggs, just the pregnancy rates are generally closer to 80%
Yeah.
per, assuming they're getting at least 12 or more eggs.
Do you find that most people who are going through third party reproduction will be able to have a child?
I would tell you I've looked at this data since 2001, that over 90% of people, if their persistency is the key to everything.
Yes.
If you want anything bad enough in life, you get there. There's 8 billion of us on this planet, so I don't have to reinvent the wheel. All I can say is, okay, if you want a baby, I need egg, I need sperm, and I need a place to incubate it. Whether or not I have the right egg, the right sperm, and the right place to incubate it, that remains to be seen. But enough of the right tries
Yeah.
using the right equipment, you should end up with pregnancy. There's no reason why it shouldn't work.
Uh-huh. That's really great to hear.
Yeah, but over 90% of people, if they're persistent between trying their own, they want to try and proceed with their pregnancy using their own eggs and sperm, then if they are willing to proceed with egg donation, we're talking for whatever reason, if it's not working and you think that it's an egg issue or major sperm issue, then I think by either if it's an egg issue, egg donation, the majority of people, 9 out of 10 people, over 9 out of 10 will get pregnant.
Yeah, and that's great. And that'll be over the course of a year, you said.
Usually, if you look at within a year, people are persistent
Yeah.
because unless someone's doing more than a year's worth of treatment, you
Uh-huh.
remember, if
I'm
you
sorry about that.
limit
Yeah.
what we can do for you, because you have your own constraints of what you want to do, either limitations in cost or limitations um, in ethically what you believe, that's what the limitations will be. So if there's only so much we
Yeah.
could do at that point.
Right. Yeah. Yeah. Well, the people at that point, I think they're so focused on having the child, and we were talking about that, right? That once they are able to go through all, when you first come to the center, I'm sorry about that phone ringing. Um, they're not hanging up either. They just keep letting it ring. Okay. So, I just turned my cell phone off in case they try there. So if, so when they first come to the center, because at this point, I'm thinking by the time they come to you, they have already exhausted quite a few avenues. And so now they're ready to embark on third party reproduction. They have to go through, when they come to you, they're kind of given a list of things that they need to complete. And
Sure.
one of them is the psych educational eval, which we were chatting about before.
Yes.
And I just wanted to say that I think that it's such an important component of not the medical workup, but the emotional workup, because the consult, and I call it a consult because it's not a psychological test or anything like that for the recipient parents, but it's really for informed consent, and it's really to allow the recipient parents to be able to explore not just about themselves and having the child, but what it'll be like to bring a child into the world through third party reproduction.
Hmm.
And because we don't want to lose sight, we spend so much time focused on having the baby that we have to remember that we're bringing this child into the world who's going to grow up and be a person, and we want them to be equipped. So helping them through, I think, the process of the third party reproduction and kind of the grief that goes along with not using their DNA is really important, and it becomes so complex on so
Sure.
many different levels.
And for some patients, I also look at it that, when just all of us, like, we think there are certain things that, number one, you never think you're going to die. You think that when you're younger, like, oh, you want to have kids, you'll do this, and you never question, can you, or will
Right.
it be? Things will be possible. You always expect that things will happen. And I think sometimes when you see that things aren't working, or your body's not cooperating the way that you think it should cooperate, um, it's a reflection of our own mortality and just being human. And I
Yeah,
think it's somewhat humbling. And I think that's why these are great things that you do, and why it's such a necessary component to just the treatment itself and the progress towards the treatment. Because I think there's an emotional aspect that I've never met anyone. I will tell you this, Laura. I've never met anyone who went through egg donation and were sad that they actually did it. The only time what I hear from people is, "I'm sorry I didn't do this sooner. I'm sorry
uh-huh,
that it took me so long to get to this point," because just having this wonderful young baby in the house, it's an amazing experience. And I think that, they're if they're lucky enough that they can even carry the pregnancy, that they don't have to use a gestational carrier. Like, remember, just because they're not giving the genetic components to the embryo. And what they are doing is they're changing epigenetically who and what that embryo and that person will become. So just because that person will grow up either in that woman's uterus, even if it's not her own egg, an embryo, um, and live in her house, that will make a difference with that individual. So that changes who and what we are. The plasticity is about 30% of how we shape other people.
Can you explain that a little bit more for people who don't know that much about epigenetics?
Yeah, so epigenetics are not the genes themselves, they're how the genes are regulated that you have. So, and the example that most people I think can understand is like IQs, for example. So, if the average IQ is 100, a genius would be like 120 and greater, and someone who's on the cognitive disability would be at the 80, an IQ of 80 or lower. So really, how you're brought up and what kind of stimulation, environment, education, the dynamics of the people you're with, um, you'll be able to mold that person somewhere between 80 and 120. Now, obviously, if someone has some birth injury or something happens, or hypoxia, something happens in utero, anything could happen that damages the brain tissue. It doesn't, the environment can't obviously sway you that much, but it still always will sway you somewhat. And that's why the environment, and that's really epigenetics, is how the environment impacts our genes and how it causes them to turn on and off at very specific times and moments in life. And it's super important. And that's what people have to realize, that they are major contributors to the donor process.
Yeah, I think that's really important. So the epigenetics kind of turns on and turns off certain things in the child, in the fetus.
In the
So
genes,
in
right?
the
So it's turning
genes.
it up. So there's expression of proteins at different points.
Mhm.
So it's just like, I think you can use the example, Mark Kelly has an identical twin brother, and Mark Kelly goes up into space for a year. When he comes back, they looked at their epigenetics. So they tested them before and then after he came back, and they were identical, nearly identical. You're never identical because you can't occupy the same space, but your epigenetics are similar because they lived in the same environment and they did the same career, I believe. But whatever it was, when he came back from space, he was completely different. So it had changed drastically in that 1 year just from being in a different environment.
I
And that's
heard
how
that it.
evolution occurs, because you're changing not necessarily the genes, but how they're expressed.
Uh-huh. Yeah, I had not heard that studied before. That is amazing.
Yeah,
To
so it's about
yeah.
30% is what it's speculated to be, the epigenetic component, which is almost equal to its importance. So it's like, nature versus nurture. This is the nurture component, right? That's the epigenetics.
Right. And does that turn on different like skin tones, hair colors, eye shades?
No, so those are the genes
Those are the
themselves,
genes.
right?
Mhm.
Right, but you're talking about other cells that are more plastic. So hair color, again, like when you look at, like they say, like how does hair turn gray, for example? So there's some type of injury or something will tell the gene to shut off, and that's why it goes from making a color to being gray. Now, the whole key is once it turns off, a lot of times you can't turn a gene back on. That's what they're trying to figure out is epigenetically. So the gene's still there and it's actually functional, but it's just shut off. It's like a light switch.
Mhm.
If you shut off your light switch and you don't ever turn it back on, you would say, I have no lights on in this. I have no lights in this house, but you do. They're just not turned on. So it's the same principle. It's just you're flipping the switches on and off at specific times. And that's what the environment does. And that's why where and who raises this child is
Uh-huh.
super important to the whole process of everything.
Yeah, from conception on.
Yeah, exactly. That's why it makes a difference. People don't real height, weight, all these things are epigenetics.
Okay, those are the pieces, the height and the weight are two that people can hold on to, and that's what I was asking about.
Height, weight, IQ. So these are important things.
They're very important. They really
Yeah.
are. So I know that you're doing different kinds of studies here because you're in charge of all the clinical research. And I was wondering if you could share some of them because they're really exciting for the ones that it works for. And it's amazing how, there's so many advances today in third party reproduction. So
Right. So for those women who are looking for before they transition to third party care and either choosing to do egg donation for the most part, and they want to try and capture the or even gestational carriers. I have patients who are coming in and they're looking to optimize. They may be of a more advanced age, very low egg reserve count for their age group, and just have overall poor prognosis compared to other age matched peers. We've been offering experimental therapy and platelet-rich plasma therapy, or PRP. PRP has actually been around since the 1970s, but it's only newly used in different fields of medicine like orthopedics, plastic surgery, dermatology, burn units are using it. They're using it in cardiovascular surgery. But since 2018, people started experimenting saying, hey, can I take the body's natural healing properties, which are the platelets? So whenever there's injury to a tissue or a structure, the platelets are what rush in, wall off, seal off the area, and then tell the cells around it to increase their DNA synthesis, cell division. And it's releasing about over 30 different growth factors, cytokines, immune modulating factors, all these different properties to just basically reduce inflammation and improve healing. It increases neovascularization of blood flow into the area. So it started out in postmenopausal or women who had premature ovarian failure or menopausal. People started using these concentrated platelets and injecting it directly into the ovary. And we found in some of these women, they started to ovulate again. And so we've now been using it not only in these postmenopausal women, because it actually works, has the lowest impact in that group because they're just more challenging because they have completely exhausted. It's really better for those who are perimenopausal or just with low egg reserve, regardless of age, or maybe even with normal egg reserve. We don't know because it's an experimental therapy. And the whole concept is that you're just changing the environment. It's again going back to the environment that these follicles are growing up, and you're trying to reduce the amount that are dying off. So follicles are in all different stages of their developmental cycle and life cycle, and they go start from primordial follicles, which are the most basic. They're microscopic, you can't see, to primary, then secondary follicles, and then eventually they transition to when you do an ultrasound and those follicles competing for ovulation in a month. We call those antral follicles. So follicles are constantly dying during this transition in life cycle. So as a result, because they're dying off, when you're putting the PRP in, what you're trying to do is reduce that impact of whatever is going on in the environment that can try and improve the amount that can survive and potentially not only survive, but also what can um, grow. And
Right.
we find that some of these follicles are more responsive to hormonal manipulation and therapy during IVF cycles when you're injecting the PRP. It's pretty incredible. No one's ever shown it, but we're doing the first double-blinded placebo-controlled trial study in the world. So I don't know, the patient doesn't know. Looking at PRP in this specific population of women 35 to 42, and we're doing PRP or versus placebo, which is just serum. So it's just a fluid of the circulation without any platelets, red blood cells, or white blood cells, nothing in it. And that's the placebo. So this way I don't know what they're handing me. And then when we inject it, we then see, okay, so the first injection starts 1 month or 2 weeks prior to the first IVF cycle. The second injection happens at the first egg retrieval. And then the second egg retrieval we do to see, okay, in these groups, are you seeing more blastocysts form, more eggs formed, and more importantly, more what we're doing is we're testing, are we getting more chromosomally normal embryos? We haven't looked at that data yet because we don't have enough individuals in the two groups combined to actually get meaningful data. But in our preliminary data, in working up towards this study that we're doing, we found that it may double the chromosomal normalcy rate in these individuals. And
Wow.
it may reduce, yeah. So if you look at CDC data, so we calculated, if you look at CDC data, in women 41 years of age and older, the average number of treatments per live birth is about 12.7 IVF cycles per live birth. A lot.
Lot. Really a lot.
This PRP may reduce that by 3 cycles down to 10 cycles per live birth.
That's significant. That's,
Significant.
that's significant. I
That's
mean,
three
I'm just
less
right.
cycles per light. Think about how many thousands of cycles that could save.
Yeah, yeah. I'm just thinking on the individual level also, like what goes into each cycle. And the more cycles you do, how much more goes into it. So
Right.
this
Right.
is,
And
uh,
there's disappointment. Remember, every time you go through a treatment, and as you know, because you speak to a lot of these patients, uh, there's only so many times you can get knocked down to the curb.
right. It's a real roller coaster. It's a huge emotional roller coaster. It really is. And just to stay, motivated to keep going is very hard sometimes.
Right. And that's why I look at it that luckily,
This is an incredible
yeah,
study.
we have these,
Yeah,
we're one of the few centers that offers this experimental therapy. There's lots of different ways that these can be prepared. And I think people get caught up in the nuances, and they're trying to say one's better than, there's no truth to any of that stuff because there's no proof that PRP, definitive proof at least, that PRP actually works. But all I can say is that when you do a treatment for someone like PRP, and the reason why it has to be double blinded placebo controlled is because if I do a therapy for you and it may not have any benefit at all, but if you believe it and I believe it, just subconsciously, we may be altering the outcome of that cycle because subconsciously we're both doing things maybe slightly differently that would alter the final outcome, which would be pregnancy. So that's why it's an interesting thing, and that's why when you look at the placebo effect itself is at least 15%, you'll get an improvement just by telling people things are better.
Yeah, it's amazing. It's an amazing
Right.
look at the study, but I didn't, double blind is fabulous. How long is the study going to be going on for?
Oh, it's going to be on for a long time because it's hard to recruit, and I'll tell you
That's
why.
what I'm thinking.
Because it will, number one, it's a fantastic price for the cycle. So what we're doing is we're doing either two PRPs or the serum injections. Uh, they get two IVF cycles with PGTA, ICSI, anesthesia, a year's worth of embryo banking and cryopreservation if they have an eligible embryo, and they get free transfer until
Mhm.
they're pregnant with their embryos. Um, yeah,
That's a
until
lot.
the first pregnancy. So for $12,000, it's 6,000 per cycle.
Wow.
So they're getting all this stuff for really a nominal fee. Um,
And if
but
you use the
compared to traditional IVF with PGTA, they'll spend 20 something thousand just on,
yeah,
probably 12 to 20,000 just on the IVF with the PGTA.
right, right. And if you get the placebo, it's not going to hinder your chances of conceiving on that cycle. Is that correct? Or I should
Well,
ask the question, could getting the placebo or being in the study hinder your chances of conceiving if you were doing IVF and you were going to conceive anyway?
well, you're doing the treatment and then you're going right for transfer after. So it's a 4-month process,
Right.
right? So you do either PRP or placebo 2 weeks prior to starting your first IVF cycle. Then you do the retrieval. You're testing those embryos, and then before you even get the results of those embryos, the PGTA results, you're already going to start your second cycle the month after.
Mm-hmm. Okay.
So 2 weeks later, a week before you get the PGTA results. So they're already maximized. So even if you're in the placebo group, you're getting 2 IVF cycles with PGTA,
Right, and it's
right?
not gonna, yeah, no, which is great, and so it's not gonna hinder you either way. That's really what I was trying to ask the question. Whether you're,
I
it's not, that's the only reason why I would think people would not want to do it. They would be afraid that it would hinder their chances of conceiving if
Well,
they.
people don't want to do it because most of the people who are looking to do this therapy are already have most of them have done multiple cycles elsewhere
Mhm.
and
Right,
have been failing, and they can't handle another failure, and they want to know that they've done the most that they can do because I can't unblind the study and tell them what they've received or not.
right,
So because then that could alter who's coming next, and I don't want to know. And so like at
yeah.
the end of the study, because you need such a large number of people when you're doing this, because this is the first study also looking at the for not on number of eggs, and that's the problem with PRP. It really looks at, most of the studies out there look at number of follicles and eggs.
Mhm.
What they're not looking at is number of blastocysts and euploid blastocysts, and that's what we're looking at. So that's why the metrics are totally different in the number of patients I need to treat to show that there's an actual difference. And that's why I look at it like these are treatments that you do, anything that's experimental, you do prior to saying, I can't do anymore. And then
Mhm.
I need to move on to something like third party. That's why it makes it a more palatable, I think, transition for most people.
Yeah, no, absolutely, absolutely, and I don't really see too much of a downside to it. unless I'm missing something, I don't see a downside to trying it, based on what you've said.
No, it's just because some people say they just want to know that they've done PRP because they only want to do X number of treatments. They're a lot. They want to move on with their life, and I get it.
Yes. Yeah, yeah, and they don't want to, yeah,
Yeah, and I do understand that, but they're missing the point that some people. I understand why they don't want to do it, but they're still getting IVF, 2 IVF cycles.
yeah, it's not gonna hurt anything. If anything, it's just
No,
gonna,
it's always a win. It's a win-win no matter what you do.
yeah, yeah, that's what you're saying. So that's, I just want to be sure I heard that. Well, I think a lot of it though is that um it takes so much to finally get there.
It
And
does.
and that's what
It
you're saying.
does.
And so then by the
Yeah.
time you finally get there, and the exhaustion, physically and
Hmm.
mentally,
Yeah.
financially, right, is just there.
Right.
And so people are ready to move on. But this sounds like a fabulous study, and so it's gonna be a long-term study, I would imagine too.
It's a long-term study, yeah. It'll probably take years to complete, but we're off to a decent start so far.
That's
And I just need about another 40 people, 40, 50 people before I can start looking at the first part of the data to
yeah.
just say, okay, is there any trends being met at that point?
Well, hopefully somebody listening will wanna join.
Yeah, anyone who wants to, please feel free to contact us. I would love to meet with you and discuss it because they can go. It's on clinicaltrials.gov. If they go to if they type my name, Jesse Hade, Hade,
Right,
and they type in ovarian PRP study, it'll bring them to uh, the clinicaltrials.gov website, and they'll see the whole consent. And the consent, it's about over 20 pages, and it lists everything, how the study's laid out, what their compensation, what do they get for it, what do they what's included, what's not included, who's eligibility, all those type of things. Because we're trying to keep it tight eligibility, because this way you want to make sure that when you're looking at the two groups that they're even in all aspects: age, egg reserve,
yeah,
right? Number of pregnancies, things
mhm,
like that.
yeah, great. I mean, it's great. I'm really interested in seeing what happens when you get enough people and you start having the study results.
Me too. Me
I
too.
know, because it really sounds phenomenal. I have a few people right now in my practice trying with PRP, but they're not in studies. They're just trying with PRP.
Sure.
What happens? It's becoming.
Understood.
But this
Yeah.
sounds much. This what I like about this. Well, there's a lot that I like about the study, but I love the fact that it's double blind for all the reasons that you mentioned, and also there's no downside there, and there's 2 cycles. So you're really,
Yeah.
and you're looking at the blastocysts, not at anything else. And the blastocyst is really what counts in the end.
Hmm.
So
Right.
it's all good. Yeah, no, that's great. So you're like a wealth of information, I have to say. I could go in so many different directions talking to you but we've been talking for a little while. I don't know if there's anything else that you'd like to mention today or talk about today that we should include about some of the work that you're doing.
I think we've hit it all, to be honest. I do all types of things. So here at Generation X Fertility, I do just all types of infertility consults. We do a ton of hysteroscopies and uterine correction of uterine surgery for uterine certain malformations. Polyp resections, identification infections. There's a whole gamut. We do almost everything here.
Right. Yeah, yeah. And unfortunately, so many people have to go through so much of what you're offering. So it's great that they
Yes.
could go there and get that. And I find that many people go to several different places before they settle on third-party reproduction.
My best advice to people who are going through it is you have to believe it's going to work. If you believe, I believe, I actually tell people, I'm an honest person. I'm honest with myself, and my limitations become your limitations. So if I don't think I can help someone, I'll tell them I don't think this is appropriate, because I'm more concerned for whatever the reasons may be, that I'm just setting you up for a failure. and that maybe you want to explore other options. But ultimately, the patient has to make their own decisions, right? It's not for me. I don't make decisions for people. My job is to educate, tell you what your options in life are. Your job is to then tell me what you want me to do for you.
That's great. I think it's a great way to end, right? So, well, thank you. Thank you so much
Thank you
for
so
your
much,
time,
Lori.
all the information. If somebody wants to get a hold of you or get a hold of the center, how would they do that?
Sure, they can reach us at generationnextfertility.com. Or yeah, they can look us up,
Okay.
they can call us, they can go online to the website and make an appointment. Really easy.
Yeah, and I do have to say, when you call Generation X, people pick up the phone. So I do have to say that. They're
Yeah, we
reading
we
out,
have
you get
we
people on
and
the
if
phone.
we're busy, we have an answering service. So we always have someone answering the phone, but always through email. People email all the time and say they want to make an appointment. So we always, well, there's so many different ways that people can do it.
Okay, wonderful. And if anybody has any questions or comments, please feel free to reach out to me at lorimetz.net. Thank you.
Thank you, Laurie.
Okay, great. I'm just gonna stop this now. This is the part. Thank you so much. I mean, honestly, this was so much information.
Yeah,
And
well, thank you for having me. I really appreciate it. That was so kind of you.
no, please, my pleasure. I just